All right, now we're recording, and just let everyone out of the waiting room. Just keep in mind that everyone's defaulted to mute, but we'll be doing introductions here in a minute, but want to give everyone another minute or so to get logged on and prepared. So want to make sure, can everyone see my screen with the slides? Yes. Awesome. Sounds good.
All right, well, it looks like we have about 15 folks on, so we have a great group of representation, and I'm sure we'll be getting more people trickling in. So thanks everyone so much for joining. I'm Elsa Weltzing, now Elsa Staples transitioning, but really happy to be joined by our whole CCSP team today, and many of you navigators and other members of our CCSP clinics, as well as a few guests for a deeper dive into our CCSP 101 content. So this one is our 102 training, continuing on from the primer we had in October. So I'm going to turn it over to Wesley to walk through our afternoon.
Great. All right, so we'll spend a few minutes just doing introductions and a brief icebreaker, only because we're going to be here for a few hours and want to make it as fun as possible while also informative. And then the agenda here, and I sent this out with the email just in case people have some areas that they really want to hone into, but we'll start with introductions, go over colorectal cancer screening basics, and program considerations, take a break, then go into capacity building for lung cancer, screening and family history, an overview and a little bit of a deeper dive into patient navigation, another quick break, and then end the afternoon with colonoscopy navigation reporting and billing. So we'll just be going into a lot more detail than we did in the primer. If questions come up throughout the presentation, we'll have time for a closeout and Q&A at the end. And then we can send out any other information that we weren't able to address here, but we should be able to have time to cover everything. So to get started, we wanted to do, because we have a manageable group here, we can go around and do introductions, share briefly what you hope to learn from today. And then I put two options here for an icebreaker question. You could either answer what sort of mythological creature you would be and why, or just a good book you've read or movie, TV show you've watched recently. So up to you there. So I can go ahead and start. I'm Wesley Lighthall. I'm the patient navigation program manager with CCSP. I hope to learn a little bit more about everyone's patient navigation insights from their roles and responsibilities list that we sent out. Curious to hear some learnings that you all had from doing that if you did go through with it. And then as far as the two options, I would say a good book that I've read recently is called How High We Go in the Dark by Sequoia Nagamatsu. And it was a sci-fi and really good. If you liked Cloud Atlas or those kinds of things, I would highly recommend it. But yeah. All right, Elsa or Andy, you want to kick us off next?
Hi everyone, Elsa again. I'm really excited to hear what everyone is interested in learning about more today, and also hear some of your tips and tricks for some of the navigation pieces. And so if I could be any mythological creature, I would be a mermaid, because very cliche with my red hair looking like Ariel, but I love water and would love to explore more of the ocean. Andy?
Hi, everybody. Andy Dwyer, University of Colorado School of Public Health Cancer Center, and along with Leslie and Elsa, and part of the team for CCSP. And I was one of the people who helped start the program back in the day. So I'm not going to tell you how long ago that was, but it was at the beginning of my career. So thanks so much for being here today. I know we have the CCSP navigators from throughout the state, as well as some of our affiliate partners who are joining in. As it might connect to part of our work with regional cancer networks. So thank you so much, everyone, for joining. And I think most of you know, I had a baby 6 months ago and feeling so sleep deprived. So as soon as I heard the mythical creature, it just made me think of the movie Napoleon Dynamite and the liger, the cross between the lion and tiger. And I'm not sure if that actually from a species and sort of an integration of different cats, that's possible, but that's the first thing that came to mind. So I don't know if a lion tiger cross is a mythical creature, but it seems like that's probably what I would be. So that's, I don't know, Wesley, Elsa, do you know, is a liger
I think
viably
they're
possible?
real, but
Are they real?
can't have babies.
Okay, well, I'm sort of real, sort of. Well, so that's funny. I think that's the first thing that came to mind today. But thanks so much, everybody, for joining. This is a fun exercise.
All right, and then we'll open it up to the group if you all just want to unmute as we do introductions, just because everyone is muted.
Hi, I'm Victoria. I'll put my camera there. My camera's not that great, but I'm Victoria. I work with Valley-Wide Health Systems, the Guadalupe Health Center and San Luis Center. And I hope to just touch base on a little bit more of the billing process. And a really good movie I watched recently was Where the Crawdads Sing. It was, I don't know if anybody has read the book or seen the movie, but it was really good. Thank you.
I'm Daylene Colglazer from Kit Carson County Public Health here in Burlington, Colorado. And I'm hoping to learn today more about the fit kits that we are going to provide to our community. So that's kind of why I'm sitting in today. And one of the good movies that I watched recently was Where the Crawdads Sing. Also, I really enjoyed that one. Thank you.
Great.
I'm Marilyn Matties. I'm from Valley-Wide Health Systems in Buena Vista. And my mythological creature would be a dragon because I'm fierce but friendly. And I want to learn today on how to get patients to call me back. And the movie I watched was Ticket to Paradise. Pretty cool.
Hi, I'm Laura Martinez. I am the case manager supervisor here at Valley-Wide Health Systems. I'm on today so I can gain a refresher to be a better resource to my team. And a book I recently read was Woman of Light by Kelly Fajardo Anstine. And I liked it because she's from Colorado. She wrote another short story book. I can't remember the title, but this book was, it referenced the San Luis Valley area, and that intrigued me.
That's a good book.
Hi, my name is Donna. Sorry, my camera's not working. I don't know why. I'll have to try to play with that a little bit. I'm from Valley-Wide in Los Animas. I don't know that I'd want to be a mythical creature. Maybe a unicorn, because I've always thought they were beautiful. What I'm hoping to learn today is a little bit more of the navigation through the whole CCSP process and helping patients with their colonoscopy scanning and everything. Since I'm still new to the position, I think it would be good to have that kind of information, a little bit more on it. A movie that I watched recently that I really enjoyed was called I'm Still Alice. It's about a lady who got early onset Alzheimer's, and what her and her family went through and how it affected her life. It was on Netflix and it was really good.
Hi, I'm Cece, Quality Improvement Coordinator from High Plains Community Health Center. I am just on so I can also be more supportive whenever we get a patient navigator hired. And a great book I read lately was called Diamond Eye, and it's about a Russian female sniper during World War II, and it's based on a actual human. It is a novel, but it's well written and a great read.
Hi, my name is Corey Walsh. I'm a regional health connector. My host agency is Centennial Area Health Education Center, and I am the Eastern Colorado Regional Cancer Network lead. And I am here to learn more about colorectal cancer and just anything that would be beneficial for our community.
This is Arlene Tobin. I am the PI Quality Assessment Coordinator at Peak Vista. This is a whole new program to me, and I'm interested in everything regarding the program. And my favorite TV show is any ice hockey game that is on TV. Thank you.
Hi, my name is Anna Moriarty. I'm a case manager here with the La Junta Valley White Clinic. And from today, I would just like to learn to be more of a supportive navigator and get more insight as to, you know, the whole process, basically. And the last movie I watched was Where the Crawdads Sing. And I'm a little late in joining, so I don't know if somebody said that already.
Hi, I'm Karisma from Valley White Health Systems. I'm a case manager. I just want to get more information regarding the process for colonoscopies. And I'm just started a book. It's an autobiography about Elizabeth Smart, the girl from Utah that was kidnapped. So I just started that while I was sick. So I don't know if it's good yet. I'm sure it will be though.
I'm Jody Stolzenberger. I am the clinic manager at View Clinic in Cheyenne Wells. I work with Keith Memorial Hospital. And we just lost our patient navigator and we're looking to hire another one. So I'm listening so I can hopefully fill her in when we get a new one hired.
My name is Lindsay. I am the health informatics specialist for Peak Vista Community Health. I'm new to CCSP, so I'm just trying to learn, like Arlene, everything. Last night I saw The Menu, and that was a really interesting movie. Would recommend.
My name is Rose Rivas. I'm a case manager at Valley White in Ordway, and I'm basically new to the CCSP and just want to get more information on a mythical creature. Nothing. I'm not too interested in mythical creatures. A book or a movie that recently watched, kind of very rare. I'm more like into Spanish novelas, so.
Hi, my name is Isabel. I'm gonna try it again. My name is Isabel. I work at Public Health Center. I'm one of the case managers, and I kind of just want to learn everything. I'm kind of new at it too, and TV shows. My husband we just watch hunting. So yeah, I just want to learn a little bit of everything for the program.
Hello, my name is Francisca, and I am from Public Community Health Center. And I am a case manager here or patient navigator. Like to learn as much as possible. Doing it for there's always something Yeah, that's new. And as far as the movie, where the crawdad sings is good. And Mr. Focus Creature, I don't know.
Is there anyone else who hasn't introduced yet? All right, if anyone else doesn't have audio or a microphone and wasn't able to introduce, we'd love if you'd put your name and answer to the fun question in the chat. Was super great to hear what everyone's been watching, listening to lately, reading, as well as some of the mythical creatures. So I also saw Where the Crawdads Sing over the weekend. So that was a fun movie for sure. All right. So we're now gonna pivot into the content for the program. So we're gonna get started with an overview of CCSP services and requirements, as well as some of the background on the cancer types addressed by the program, expanding upon the information that we initially introduced during the first primer session of our CCSP 101 Part 1 in October. And we're really excited to share also today that the CCSP program guidebook, also known as the program manual, has just been fully updated and aligns with the information covered in today's training. So throughout the slides for today's session, we've referenced where in the guidebook you can find additional details and resources for many of the topics we're going to discuss. So the guidebook has been published under the program's documents section on the CCSP website. The direct link is available on this slide and will also be sent out in the follow-up email after the training, along with the slides and recordings. So really happy to have finally some more up-to-date information and statistics throughout the guidebook, and really making sure it's current with the structure of the program. Next slide, Wesley. So CCSP is really focused on reducing incidence and mortality from many of the top cancers in Colorado, because cancer continues to be one of the major causes of death and suffering in our state. However, cancer used to be the leading cause of cancer death in Colorado up until this past year, and is now the second leading cause of death in the state. Next slide. So CCSP is addressing focus on many of the cancers with the largest burden in Colorado, including colorectal, lung, and many of those cancers that have a hereditary risk component and may be associated with hereditary syndromes, such as Lynch syndrome, which is associated with colorectal cancer, prostate, and uterine cancer, as well as hereditary breast and ovarian cancer syndrome, which is associated with higher rates of breast and ovarian cancer, and colorectal cancer as the primary focus of CCSP, and historically the focus of the program, is the third leading cause of cancer incidence and mortality among both men and women in the state. And CCSP is the only statewide colorectal cancer screening program in our state. And also I wanted to point out that while rates of smoking have been continuously declining, which has had good news for incidence rates, although it's still high, lung cancer mortality is still the leading cause of cancer mortality in the state. So this demonstrates a need to intervene with screening for those who are eligible. So you can learn more about the current statistics for these cancers in the CCSP guidebook. Next slide, please. So since CCSP's inception in 2006, the Colorado Cancer Screening Program, formerly known as the Colorado Colorectal Cancer Screening Program, has supported participating safety net clinic systems with utilizing patient navigation and other evidence-based strategies to improve access and uptake of cancer screening for those who are medically underserved in Colorado. We're currently in the last year of the current grant cycle, and the program has been funded through this point through the state tobacco tax revenue through the CCPD grants program. And we hope to have more information to share about our application for the next CCPD funding cycle soon. So if CCSP is refunded through this grants mechanism, the program will continue to be focused on colorectal cancer screening with an expansion to other evidence-based interventions beyond just patient navigation, but will also continue to ensure that clinics receive resources and support for hereditary cancer and lung cancer screening as well. Next slide, please. So I'm not going to spend too much time on the services provided by the CCSP program, since many of you that are part of a participating clinic are pretty familiar with these. But currently the main focus of CCSP is training and technical assistance for colorectal cancer screening, including colonoscopy navigation, as well as supporting clinics with building capacity for stool-based testing, lung cancer screening, and hereditary cancer risk assessment. So we reimburse on a fee for service rate for navigation into colonoscopy. And we're also supporting a subset of clinics through mini grant awards with their capacity building projects. Our trainings and other programming are often open to many partners working across the cancer continuum, as well as patient navigation in the state. And so, as Andy mentioned earlier, we have some guests joining us today from the Eastern Regional Cancer Network who are going to be focusing on some colorectal cancer screening interventions. Next slide, please. For patients to be eligible to receive services that are supported by CCSP, the primary indicator and requirement is that patients have a household income that's at or below 400% of the federal poverty level. And federal poverty level guidelines are updated annually. So in the CCSP guidebook, we have a link to the federal poverty guideline calculator, as well as the current rates for 2022. And the 2023 rates should be available by the end of the month. But for clinic or patients that are in need of screening, as long as they meet this income threshold, insurance type doesn't matter. They can have any insurance type or be uninsured or undocumented, and just need to be eligible for screening based on medical guidelines. And also patients who are in need of a colonoscopy due to surveillance needs, or also as follow-up to another non-invasive screening test, or if signs and symptoms of colorectal cancer, are also eligible to receive navigation services. So I'm now going to have Wesley bring up our first poll for today as our first knowledge check. So the question is, which groups of the following are not eligible for colonoscopy navigation through CCSP? So choose which one applies. And we'll give about a minute for everyone to answer. All right, 5 more seconds. All right, Wesley, we can go ahead and end it. So the majority of everyone got this right. So all of the above groups are eligible for colonoscopy navigation through CCSP. This includes individuals who are younger than the screening age of 45, who are at high risk and may need to start screening earlier or are symptomatic. So for average risk individuals, the age is now 45 to 75, but those at high risk or with symptoms may need a colonoscopy at an age earlier than that. But great job, everyone. All right. And I just wanted to briefly highlight a little bit of the data showing the impact of the program to date. So based on all of your hard work of you, our navigators, and all of our clinic teams, more than 36,800 colonoscopies have been completed over the life of the program. And in this current grant cycle, 9,582 were completed through June 2022. So bravo, as Laura said in the chat. This is a huge accomplishment and really reaching those patients who are most in need. And also Brunner Caritas was our first clinic system to fully integrate lung cancer screening into their workflows. And they've screened 82 patients so far in this current grant cycle. And then the second half of FY 2022, we started tracking stool testing data from clinics participating in the capacity building work to better track the reach of all colorectal cancer screening methods. So already in those first few months, more than 2,000 stool tests were administered, but we're expecting to see much higher numbers in this fiscal year. So round of applause to everyone on the call for all of your hard work for making this possible to reach patients in need. Next slide. And our mission is really focused on reducing health disparities for cancer screening. So your clinic systems are successfully reaching nearly equal proportions of men and women for colonoscopy navigation. And over 50% of those screened identify as a racial or ethnic group other than non-Hispanic white. Most patients screened have public insurance or are uninsured, and the program is successfully identifying both cases of cancer as well as advanced adenomas that have a higher likelihood of developing into cancer. And by catching those before they turn into cancer, we're saving lives. Next slide. So now I'm going to turn it over to Andy for the deep dive into all the colorectal cancer screening basics.
Okay, so thank you so much. And also, I think it's great to see all of the statistics about the programs and accomplishments. So this couldn't really be possible without all of you working statewide. So what I want to just say is ultimately what we know is that ultimately the incidence of colorectal cancer is largely going down in people who are over 50 years old, mostly because of population-based screening the last 15, 20 years, really the changing guidelines in terms of looking at management with stool-based testing, looking at management with endoscopy approaches, which is the bottom, really if you look at the 50 to 64 and 65-year-olds, and even for mortality rates, you see because of a result of screening, incidence and mortality have largely gone down in people over than 50. But one of the things that's happening, and many of you are either seeing this real time or seeing the trends, unfortunately, there's a startling number of people who are diagnosed with colorectal cancer between 20 to 49 years of age. And this is something that's come up because the mortality rates have definitely looked at some decreasing rates, but then also up and down a bit in terms of mortality, because we know that a lot of people who are diagnosed before the age of 50 years old end up with aggressive cancers because they're found later in a population who aren't normally thinking about colorectal cancer. So there's a lot to be said about the role and really seeing the success of navigation and screening navigation and using screening modalities. But there's a lot of room for improvement as we look at this area, and particularly in the medically underserved. And then as we think about the group who are now 20 to 49 years old, what this really means. But some of the great things that have happened, of course, and we'll talk about the changing guidelines, is the American Cancer Society led the way, also with U.S. Preventative Task Force, with also recommending screening for those who are 45 to 49 years old, in addition to those who are old, over age 50. So we've got a lot of good work to do, but we've made some great progress. And again, that's because of many of the efforts and statewide programs and a lot of effort put forward. So congratulations, because the statistics that Elsa showed earlier are really what drives this great reduction in incidence and mortality. So next slide. So if you really look at in terms of what we just saw previously, but what we're also seeing in Colorado, we also see ultimately the same trends. So again, in terms of looking at incidence and mortality, we're really seeing a decrease in incidence, but also in terms of the 50 and over, but also for that 40 to 49, still seeing a little bit of a plateau and sometimes an increase. And really not seeing that rate overall going down. So we have a lot of really great work to do in terms of outreach awareness. And then again, really making sure that you're all aware of the opportunities for screening moving ahead, which is what I'll talk about based on those guidelines and management of patients. Next slide. So one of the things that we also track in concert with our state health department is also really looking at regional type of approaches in terms of the data which we're showing. So I want you all to find your county. So I know there's people from Mesa, there's people from the San Luis Valley, there's people from Eastern Colorado, from Front Range. So if you can look at your catchment area and look at your county really quickly, what you want to do is, first off, this really relates to colorectal cancer screening. So the darker the shading in, or the darker the color, ultimately looks at late stage colorectal cancer incidence. So if you're in a region that has that darker red orange, you're looking at people who have later stage disease. So that's where a diagnosis might be happening in a stage 3 or stage 4 patient predominantly, or we're seeing a predominant proportion of those patients really with the higher rate of incidence per 100,000. Those are later stage cancers. So in the northeastern part of the state, overlooking at Mesa, even the darker range into southeastern Colorado, that's where we're seeing some of the larger and more late stage disease, also with the red in that specific area. So the lighter stage is where we're seeing not as quite delay in diagnoses and probably later stage disease. If you look at the dot, the darker the dot is and the smaller the dot, that means the lower the screening rate. So if you see a late stage and a low screening rate, you know that there's probably some correlation with number of people who are being screened and that ultimately seeing later stage diagnoses. But conversely, we also see some great area where we see good gains. Like, so for instance, in Douglas County, a higher number of people looking at those screening rates, and then ultimately the lower stage of incidence. So those are the kind of things that we want to look for. And then we see that etching ultimately is looking at the federal poverty level and the people that are living at a certain income level. And ultimately, you see those that are more etched are people that ultimately have lower wages and overall lower family income. And so we really want to look at this proportion and this relationship between later stage incidence screening and then ultimately what's going on in terms of eligible population for the programs that we're administering. So I bring this up in this table because I think it's a really good thing to think about what's happening in your community, having messages with your clinic system, with patients about what's happening in our state and what it means for your region. But we're going to continue to keep a pulse on this so that we could also think about what kind of resources we're administering through CCSP throughout our region, because our state, our approach is to be statewide and looking at cancer prevention and control, as Elsa said, is one of the only programs that provides statewide screening navigation for anything other than breast cancer. So we definitely have put some time into colorectal cancer. It's really been our main focus, but we're using the lessons learned for the hereditary cancer, as well as looking at lung cancer screening as well. So this is something that will be made available to all of you, but again, just trying to keep the tab on what's going through the state and how we really think about the populations we serve and administration of resources. Next slide. So we're going to talk a little bit about the GI portion in this as we move forward, because it's really pivotal to understand the type of screening modalities and the anatomy. So one of the things that I think we should all become very familiar with, and we have different types of graphics that we can provide to all of you, because I think for patient teaching and patient learning, as well as all of us understanding the GI tract, it's really instrumental to really thinking about colonoscopy, cancer prevention, and colorectal cancer prevention. I bring this up just because I do think that within patients and many navigators really thinking and understanding the different anatomy can be confusing. And sometimes patients can really get a number of the types of procedures as well as understanding of what's going on with anatomy. It can be confusing, but it doesn't have to be. And so I do think that if you have something that's an anatomy handout, I know we have different patient models, please communicate with us that if there's anything you need in patient teaching that we can provide to you to even help relay some of the messaging and the information that's shared today. The idea would be information transfer to patients. So we can start and then talking, of course, that when we're talking about colorectal cancer screening, we're really talking about the large bowel. As you can see, there's the upper GI, which is the stomach, the esophagus. Even the small bowel is a different part, but when we're talking about the GI anatomy as it relates to colon and rectal screening, we are talking about what we're calling the bowel or the large bowel. And so that's really thinking about the cecum, ultimately thinking about the ascended colon, the transverse colon, descending colon, sigmoidoscopy, the rectum, and the anus. And so as you can tell, that pointer is moving around right now. But as you understand, this is like a large tube that really helps with the final extrication of the absorption of nutrients and really thinking of excrement that has to evacuate from the body. But this is really the place where we really think about the changes in cellular change or even anatomy that can lead to colon and rectal cancer. One of the things I want to say is the anus is not something, anal cancer is not something that's included in colon and rectal cancer. Biologically, it is very different anatomy, very different treatment. But I do think anal cancers are also on the rise with HPV and the like. So it's something to definitely keep in mind. But for the colon and rectal, we are thinking of the colon and rectum typically as sort of a combined disease source to really talk about prevention and control of GI related cancers. So again, this is really one of the things that that's noted in the guidebook, a really great teaching opportunity. So patients are really clear when we're talking about colon and rectal screening, what is including, and that is included the colon and the rectum. So I do think there is a poll. Elsa, we have a poll here right now.
Yes, Wesley is pulling it up.
All right, perfect. So when we're talking about GI screening, is a small bowel or intestine examined during the actual visual examination of the colon and rectum and for colorectal cancer screening? So 100% no, we got 3 out of 3. Do I have any votes? Okay. All right, so you are exactly right. Right now, the large bowel is the only thing that is that is examined, and the small intestines are not part of that as well. And many of you hear about the upper GI. That is a completely different type of procedure that can look at different types of issues related to the esophagus and stomach. But I should also mention that like colon and rectal cancer, stomach cancer in young people and in general is also on the rise. So something to keep in mind as well. Okay, next slide. So you guys are whizzes. So when we talk about the colon and the rectum, within the colon, there really is, and so you can really think about this. Basically, if you think about the colon as a tube, what you're seeing on the inside is one side of that tube, one side of the hose. And so ultimately, what can happen over a series of time, or because of a specific familial or genetic risk, there can be the development of what we call polyps, or basically tissue that start to develop. And as you see here, ultimately, these types of growths can start to really come and start to develop as abnormal or even sometimes somewhat normal cellular growths that really start to kind of really amass. And so ultimately, the smaller the polyp or the smaller the mass, And that as long as the cells aren't changing, those can be what they call aplastic, or sometimes really like not dangerous types of adenomas. But as these clumps of tissue start to become larger in size and those cells start to change, that's when we start to see those known as adenomas generally start to become advanced adenomas, and those become high risk, precancerous, or even cancerous like cells. So when you, or type of growth. So what you see here is you see again, those cells starting to amass. The larger they become, the more those cells start to change and became aplastic or really disruptive, the chances of those becoming cancerous are really quite high. So you'll see that little dotted line to the left, you see like a medium risk, a high risk, those are advanced adenomas. But as those adenomas actually start to develop, start to bleed, and start to move through the tissue and even out of the bowel into other types of the organs, that's where we actually seeing cancers develop. So ultimately, these can either be what we call pedunculated polyps. So the one that it's like, looks like it's on a tree stalk, that's rising up off of the colon where it looks like a little bit of a tree. Those are easy to come and grab out with a colonoscopy. If they start to bleed, which sometimes advanced adenomas and cancer do, that's where we see the opportunity with stool-based testing. And then ultimately, when we see these sort of development, this can happen over about a 10 to 15 year span. So ultimately, we know colonoscopy happens or actually, I'm going to say that because I think that's one of our poll questions here, but we know this sequence to develop over 10 to 15 years. And that's essentially what we're looking at and why those recommendations follow suit. So a lot of times the age is one of the biggest risk factors, again, genetic or family history for these cellular type of changes and growths. But many of these polyps can live on these stalks. They can be flat polyps, and then some of them can even amass to bleed and not to bleed. But that's why preventive cancer screening is really one of the biggest opportunities, because it's preventable, beatable, and treatable if we remove these stalks or we look at early detection with bleeding or cellular change. So diagnosis and staging is included in our guidebook for CCSP on page 27 and 28 to learn more about this. But essentially, we're really looking at this type of growth for us to really think about cancer prevention and control as it relates to colorectal cancer. Okay, next slide. So let's talk a little bit about the average risk population. And I had mentioned previously that age is one of the biggest risk factors. So most of the time for people who are 45 to 75 years old, colorectal cancer starts to develop because within that tube and those polyps being able, that there has been basically cellular change because of the toxins, because of the excrement that really causes those sort of changes, those sort of situation. For the average risk population, they are usually symptomatic, who have no personal or family history, and age is the biggest risk factor for them developing colorectal cancer, just because it is what it is. The American Cancer Society, as I noted, as well as the U.S. Preventive Services Task Force, ultimately recommends screening starting at age 45. That's moved from 50 to 45 because of ultimately that average risk population. And I just want to remind everybody, this is not people who have Lynch syndrome, have any genetic or familial syndrome, or even have a personal history of colorectal cancer or advanced polyps in their family. Those are all what we consider increased and high risk individuals. But for the average risk population, that's what we're talking about, is age is the biggest risk factor starting at age 45. I just want to remind everybody, we did make that move from 50 to 45 within the last couple of years. So this program really intends to spend a lot of time also messaging between 45 and 49-year-olds about the need for increased screening, because it's one of the biggest groups of people where we see diagnoses happening at this time. So we want to spend a lot of time and effort into moving that forward. Next slide.
And real quick, I just want to mention that all insurance payers have to start covering colorectal cancer screening at age 45 as of January 1st, 2023. So most have already moved towards that, but as of January 1st, if insurance payers are not already covering individuals for screening at age 45, they now have to do that. And that includes Medicaid, Medicare, and private payers.
Yep, fantastic. And so CCSP, Fight CRC, Colorectal Cancer Alliance, many folks are working to make sure that insurers as well as folks who are looking at coverage issues are aware of this and really advocating for that. So we haven't heard a lot of pushback, but to Elsa's point, it's absolutely mandatory that those insurance providers do provide coverage for that 45 to 49 group. Okay, so that was what we considered average risk population. When we really think about high risk and increased population, we are thinking specifically people who are at increased risk because they have a family history of colorectal cancer, polyps, or any of the GI diseases. When we talk about increased risk, we're talking about people typically who have a first-degree family member. So that is a parent, a child, or sibling who's had colorectal cancer. So specifically in my family, my mom had colorectal cancer at 42. I really should begin screening about 10 years before that diagnosis. So at 32 is when I should have had my first colonoscopy. It was more about 35 years of age, but we really want to keep track of what's going on with our parents or siblings, and even if our kids have had colorectal cancer, because even if you start screening before, or if there's been a diagnosis before the year of 60 years old, you can begin screening as early as 40 years old because of the increased and high risk because of that specific situation as it relates to first degree family members. Ultimately, if we see other individuals that have Lynch syndrome, FAP or anything, they can actually start screening as early as teens and early as beginning in their 20s based on the risk and the surveillance guidelines. But essentially, when we think about increase in high risk individuals, we are thinking of people who've had advanced adenoma in their family, as well as colorectal cancer in their families, and need to begin either screening 10 years before that person was diagnosed, or if that person was diagnosed before the age of 60, at least at a minimum age of 40. So we have these guidelines in the guidebook for CCSP, but the real name of the game is right now, in terms of the multi-task force and the colorectal screening, as well as NCCN, there's a specific set of guidelines that are for the increase in high-risk population. Those are a little bit different than USPSTF or ACS guidelines because those are for the average risk. But again, speaking to Elsa's earlier point, people who are at increased or high risk or at average risk, they are covered by insurance. It's just very important that we document the reason that they're getting screened so that there's any question that there's viability for making sure insurances cover those. So one of the things I just want to mention, of course, though, that is if people are at increased or high risk, colonoscopy is the only type of exam that can happen for those people. They are not eligible for stool-based testing. They're not eligible for other types of screening. It's ultimately for the high-risk individuals that they have to do colonoscopy. The average risk individuals are eligible to have a variety of tests, which we'll talk about in more depth, based on stool-based screening, advanced CT imaging, or colonoscopy. But at this time, we really aren't recommending high-risk individuals have anything other than colonoscopy. Next slide. So ultimately, if we really look at the types of screening tests, we're talking about stool-based testing that include the stool-based tests, which are FOBT or FIT kits, fecal immunochemical, or ultimately stool DNA. And then ultimately, the differences between those are the guaiac-based testing and the fecal immunochemical testing are really looking for human hemoglobin. The stool DNA testing are looking at human hemoglobin and any sort of cellular change within that test as well. So it's not just blood, but it's really looking at any cellular change. So these are great tests. They're used for the average risk population. The pros for the FIT and FOBT are there's no bowel prep. They're done at home. In terms of looking at the stool DNA, there's no bowel prep, sampling done at home, and they have the added benefit of also not looking only for blood, but for stool DNA. Ultimately, the cons on these tests are that they have to be either done annually or every 3 years to stay in compliance. That would mean that all the clinic systems would have to have a proper way to manage patient follow-up, to do that education, and to make sure, again, that it happens either annually for the FIT and FOBT or every 3 years for the stool DNA. And again, a reminder that any of these tests that are done for an average risk population, the one thing that absolutely has to happen if any of them are positive is a follow-up colonoscopy. So again, for the average risk population, they can use stool-based testing, they can use visual examination, but if there's anything that's found, all roads end up in colonoscopy. For the visual examination, that's the colonoscopy that I'd mentioned, and that's really a tube that can go through that colon and rectum, as we talked about. It can really look at those polyps. It can really look at any abnormalities or bleeding. It has a camera at the end with a light. You can look and you can see. You can also extract with a loop with little snippets that can remove those polyps or even biopsy tissue. So that's really the opportunity for prevention real time. Again, only high-risk individuals will, or if you're high risk, the colonoscopy is the only type of test that you can have. But also the other type of imaging are also a flex sig or a CT colonography that also visualize that colon and rectum area as well. The CT colonography, again, much like the colonoscopy, allows for that visualization. It's just that there's ultimately a camera that really looks at, or like an X-ray where they can ultimately see the different slices and see if there's anything that's happening through the visualization. Like colonoscopy, there has to be, there's no sedation, and unlike colonoscopy, there is no sedation, but there is bowel preparation needed. And there's insufflation in the into the tube so that they can really puff up the bowel and really see what's going on through these series of x-rays that happen through the CT colonography. But like colonoscopy, there is a requirement for bowel preparation. So in order to do that, there has to be basically a bowel preparation that happens. There has to be reduced and looking at dietary changes in terms of looking at a no colors, no dyes, a liquid type of diet a couple days before, and even light meals a couple days before. A flexible sigmoidoscopy is also another type of exam that looks at the up to the sigmoid colon. It's fairly quick. Usually sedation is not utilized. It does not require a specialist, and it can be done every 5 years. But again, that doesn't actually see the entire colon. It's just up to the sigmoid colon. So these are really great tests in terms of average risk population, the CT colonography, the flexible sigmoidoscopy, the stool-based testing for average risk folks. But colonoscopy is the one that is needed for those who are high risk. But again, if anything's even found through the CT colonography or the flex sig, all roads lead to a colonoscopy for the follow-up. So just a bit of information. These are all included on the guidelines in terms of approved test. The great thing is that there are many options for patients, but oftentimes choice can be difficult for patients as well. So really understanding what's covered by their insurance, which all of these should be through preventive services, but there are some outliers on occasion for different types of insurance plans. Most of them should be covered for average risk population. But just as a reminder, if you're seeing patients who have blood or changes in their stool, also that ultimately a colonoscopy should only be used as well for those patients who are at increased and high risk. Next slide. So again, just a quick idea and just a kind of a look-see at what these look like. That colonoscopy is a camera in a tube that is inserted into the bowel, into the rectum for visualization. It has a camera seen on a screen so they can see really what's happening inside. The flexible sigmoidoscopy also gives that same opportunity, but it only goes as far as the flexible sigmoid. A lot of patients who have obstructions or have other issues can use a flexible sig, and sometimes that is recommended for patients. And then ultimately there are a number of cancers that develop up through the flexible sigmoidoscopy, so it's still on the recommended guideline, but again, it does not see the entire bowel. That CT colonography, as I mentioned, does ultimately like x-rays and slices, so we can see all the way through the colon what's happening, and that's where you can visualize those polyps that are sometimes growing. So those are always the visualization type opportunities. The stool-based testing, the FIT kit, the FOBT, again, are the tests that are looking for human hemoglobin, whereas the Cologuard is half looking for blood in the stool and half looking for other cellular changes. So these are really the menu of options. I would recommend that if you haven't seen these, if you get a chance to observe a colonoscopy, if you have a chance to go to the lab and see what type of tests that you use in terms of stool-based testing for FIT over FOBT or even Cologuard, it's really worth your time to really spend some time understanding what are the different options, and through your facility and who you work with, who's providing those options as well. Next slide. So one of the biggest parts of the patient navigation, and where we know that navigation makes the biggest impact for colon and rectal cancer, is really through the bowel preparation. So for the visual exams, which are the colonoscopy, the flex sig, the CT imaging, ultimately the bowel prep is required. So you need to do this in order to see and find the abnormalities and also the polyps. It requires that changes in diet and fluid restrictions that might be varied based on the different types of preparation that are needed. And navigators, again, play a huge role in terms of reminding patients of when the exams happen, being very clear with their GI provider about what type of bowel preparation is required, how patients can ascertain that bowel preparation, and then ultimately really navigating them through that process to get this done. Part of that is even understanding that if there's things like blood thinners or any type of other medical recommendations, that it's clear about what type of approach patients should utilize in terms of prepping for that exam. But in terms of the actual bowel preparation, that is really ingesting the specific types of fluid to make sure the bowel is game ready for the visualization exam. So for the CT colonography, for the colonoscopy, and as long as the visual or the flex sig is not emergent, having that opportunity to cleanse the bowel is very, very important as well. So bowel preparation is really great. One of the things I can say is that when we first started CCSP, a lot of the GI providers that we worked with essentially said that they were reticent to really take patients from our program and from the FQHC's Rural Health Center and Safety Net clinics, because a lot of times patients weren't showing up with bowel preparation, weren't showing up for the exams. So we oftentimes had no-show rates of over 50%. The bowel preparation wasn't completed. And so we had a lot of strife and a lot of resistance from the GI community accepting patients. But as Elsa showed earlier, with adding navigators, all of you really streamlining these opportunities for navigation, as Wesley's going to talk about, we really have refined that process for making sure patients are prepped. And our rates are really over 90% for both in terms of patients showing up and how that bowel prep so they can really have the full exam. I just want to remind you that if this is not done well, what really will happen, just to be really straightforward, is that if there's poop still remaining, if there's, basically excrement still wrapped around a polyp or in there, you won't be able to see these polyps. You won't be able to advance the camera, and patients really won't have a good exam. And so that's why the bowel preparation is really, really, really necessary. They have to see that colon, they have to see these polyps, because ultimately it could really result in patients not having a full examination and even a cancer diagnosis if these things are missed. So bowel preparation is really critical for the work that we're doing. Next slide. In terms of the prep instructions, there's essentially, as noted, that every type of GI groups use a slightly different approach or even bowel prep. So this is just really kind of a generalization, but typically what most groups recommend is 1 week before the colonoscopy, the navigators need to start reminding people, grabbing that preparation, making sure that it's been dispensed from the pharmacy, making sure there's instructions, making sure that they're clear, making sure with the GI group that they have a clear plan of who's going to remind the patients and giving those instructions. But 1 week before, either you or the GI group should be really making sure that the patients have all the material that they need in hand to make sure that they have all the dietary, as well as the medication implications, as well as the prep solution and ready to go. They're clear about when their appointment is. And it's not just about clear when the appointment begins, but it's ultimately how far in advance should they prepare using this bowel prep that they have to drink, as well as changes in their diet to be sure that they truly are cleaned out before the procedure. The 2 or a couple days before, they're going to need to start drinking plenty of water. They're needing to eat less, not as many bulky foods, so not strong steaks, things that are more fibrous in nature to make sure that the colon is moved out, maybe drinking plenty of water to make sure they're hydrated and clean. And then the day before is literally when they start with that bowel preparation and ultimately making sure that they have that clear liquid diet. So that's no red or blue or purple liquids, because it can mimic blood or looking like a dark color that might actually cause a false sort of positive or false read for like a biopsy or something that might be needed. So staying away from, the red or blue tinted Gatorades or the juices or any of those sort of jellos. But what they're going to want to go with are basically things that you can see all the way through. So that's water, clear broth, clear fruit juices, not like orange juice. It has a lot of pulp, coffee or tea, plain gelatin, popsicles, and sports drinks. But again, no red, blue, or purple, because they do mimic the color of blood. So these are the types of things that are going to need, and this again is just a generality. It's very, very important that if you don't know who your GI provider is, and you're not clear about what they're doing or what you're doing in terms of prepping the patient or who's actually dispensing the bowel prep, figuring out that process is going to be pivotal. And we're going to be walking through a how-to to get that done as we talk about the navigation component moving forward. Next slide. So again, the guidance for the navigating patients through this process is in the bowel prep resource. This is in one example of maybe how to get patients quote unquote game ready. Stay near a bathroom, maybe don't have family and friends over the day before because you're going to have to be sharing a bathroom. A lot of times people say the bowel prep is almost similar to like a mild stomach flu where you have to be towards the pot. You have maybe a little bit of discomfort. You just really want to make sure that you're in a place where you feel comfortable. You have access to soft wipes for the for your tush because of the constant wiping. Find ways to keep yourself entertained. Really think about that bowel preparation. There's ways to ingest that, such as drinking through straws, and making sure to hydrate. Those follow-up instructions, you're really clear about what to do next and that you're planning ahead. But what I want to say is each one of you around this table is really going to be instrumental in thinking about how to become game ready for colonoscopy and even for the stool-based testing in terms of planning if and how, when that's going to work, the reminder system and that tracking system as well. So we're going to talk more about this, but those resources are available in terms of thinking about bowel prep and the like. But again, if you have not visited with your GI provider and you are not clear about what the GI team is doing and you're doing, that's something that must absolutely happen. So you're clear the type of bowel preparation they're using, their processes, and who's doing what. We want to make sure that patients aren't getting 4 or 5 phone calls that are redundant or that we're duplicating or stepping over each other. So it can be oftentimes that the primary care group will do certain things and the GI group will do certain things, but sorting that out is going to be pivotal. Next slide. So key considerations moving forward is that we can reimburse ultimately for navigation for the visual exams. There's ultimately that reporting that happens that if you're navigating for this group, there's monthly evaluation and reporting that's required for reimbursement. Most of you who are on this call are navigating for CCSP. So I just want to remind you that if that's something you're doing, we want to make sure that we have the eligibility, the billing, the evaluation, and Elsa can talk about that moving forward. If you are interested in the stool-based approaches or the capacity building for that work, that's something that we can help with as well through the grant. And that ultimately that we want to just remind people that any sort of exams that are used, like that stool-based testing, CT imaging, or FlexSig, that there has to be that navigation into colonoscopy and that association with the GI provider. And that's something that we can help with as well. There is financial assistance that's available, somewhat limited through Colonoscopy Assist and the like, and we're working on some specific strategies moving forward. But ultimately, navigation is the name of the game, and getting people into screening so that they adhere to endoscopic screening is really what the program is about as we related to colorectal cancer screening. So navigation into colonoscopy, capacity building for stool-based testing is something we can provide on a more limited scope, but really navigating people in. So the goal for this year is almost 3,000 patients to be navigated, and many of you are really carrying that burden in terms of helping us really get to this goal right now. So tons of great work happening throughout the state, and congratulations here. Next slide. Elsa, do you guys want me to, I can't remember if you want me to continue this part as well.
Yes, this is the last slide in this.
Okay, cool deal. In terms of really thinking about evidence-based interventions, we just want to also remind everyone that following the evidence-based interventions that are recommended is something that we would like to continue to do through the program, and we do have some resources. So reminders, one-on-one education, small media, provider reminder and recall systems, assessment and feedback, and standing orders. These are all noted in the guidebook in terms of ways and strategies to increase screening. These are areas that we really adhere to based on the navigation. And we do have some opportunity for some of these additional components based on the patient education, the reminder, the assessment feedback, and the like. So this is really the name of the game. This is what we're implementing. This is what we're about. We do stay true to looking at tried and true practices to improve screening. And just want to remind you all that this is something that we support. And if you have any questions about this work moving forward, please let me know. And I will pass it over back to the team. So Elsa and Wesley, it looks like we have a time for a little bit of a break. Is that correct?
Yeah.
Wesley, what's our timing like?
So I think maybe if we take just a 5-minute break, people can stand up or get some water, because we're at an hour. And then from there, we'll come back and move into the next portion. So it's 2:06 right now. So if people want to be available to start around 2:10 to 11, that'll be great.
Okay, great.
Awesome. All right, it's 2:10, almost 2:11. So we'll move on to the next portion. And for the next hour, we'll be doing the capacity building for lung cancer screening and family history, and then diving deeper into patient navigation. So Andy, if you want to take the reins here with the capacity building section.
Sure. And Elsa, I think you're doing the family history. Is that correct?
I could definitely do the family history.
Okay, cool. I feel like I've been talking so much today. So we're going to talk a little bit that as we built out the base for the colorectal cancer screening and navigation as the leading cause of cancer death in Colorado, lung cancer is definitely something that we need to tackle. So I think that in conjunction with the great work that's happened with breast and cervical is also with our colorectal. We really want to spend some time really thinking about how we build this capacity for lung cancer screening, and something that we've woven into our work, as well as family history as well. So next slide. I just want to remind everyone that lung cancer screening, there are some specific guidelines that have been recommended. Ultimately, these are based on low dose imaging, and this is basically rectified through the United States Preventive Services Task Force, where they updated their guideline to start screening at age 50 to 80 years old of currently smoking or quit within the last 15 years. Looking at the 20-pack year history and a shared decision-making approach that is mandated. So ultimately, we are following the U.S. Preventive Services Task Force guidelines. There is a recommendation about how to develop and how to quantify the years pack calculator, which I think sometimes people can find a bit confusing. It's definitely outlined within our guidebook. There's several of you on the phone who have invested in lung cancer screening capacity work, but I would just recommend that if all of you are considering this, if your primary care docs and your team are really thinking about QI initiatives, this is still a really great area to focus, and an area where at the university, as well as with many of our other programs, we are going to be spending more dedicated time moving forward. Referrals cannot be given until a shared decision-making is met, which I think that has to be typically with the recommendation of a mid-level advanced practice, or Elsa, with the guideline change, can navigators now be a part of that as well?
Yes, technically they can be. It is up to the referring provider who they're putting in that role, but it no longer has to be a licensed or a advanced practitioner doing it anymore. So perfect. Sometimes MAs, sometimes navigators.
Yes, so this is a great opportunity for CCSP as we continue to really think about the role and function of navigation, and really allowing all of you to work in this way. Once again, there is a CPT code, much like the colorectal cancer screening, that is devoted to the guidelines, so there is reimbursement. And one of the things, and I think Cheyenne Wells and others are really continuing this work, is you're building the guideline. It's really imperative that there is, if someone is a follow-up and needs follow-up testing, that is also set in guidance as well. So that's something our program can help with. It's something to really think about, but the guidelines are in recommendation. I think it's still kind of a little bit it's new for folks, the idea of lung cancer screening, but it's really are for patients who are asymptomatic and willing to follow the USPSTF guidelines, as well as with systems who have an opportunity, and patients who are willing to have follow-up tests and treatment. So within the guidebook, this information is noted. If you're interested in the lung cancer capacity work, we do have limited funds. Most of it has been sort of called for by the clinic systems we're working with. But again, we are willing to help support any of our CCSP clinics as we have resources available. And again, I do think as an emerging area, this is something where we should spend a lot of great time and devotion. Elsa, anything to add about the screening guidelines?
I think that's the main overview of the basics. We recently did have a specific session on our CCSP monthly call that was focused on the shared decision-making visit. So that recording and slides is on the CCSP website, as well as some example videos that go into more of all the lung cancer screening components.
Okay, cool. And I'm tired of hearing myself speak, so I'm going to put Elsa on the spot and talk about the genetic and family history.
Thanks, Andy. So when we look at cancer risk, the majority all cancers do have a genetic component due to genetic changes. However, many of those mutations that ultimately lead to cancer development are sporadic. So in 70% of cases, there's not that family history that runs on one side of the family, and there's not a hereditary risk. However, the research has showed that about 5 to 10% of all cancer cases have a hereditary component. And so those are mutations that are passed down among family members and can be inherited at birth. There's another 20 to 25% that where there's clusters of cancer cases in a family, so that's familial. However, these patients or these cases are not due to a hereditary mutation that we know of at this point. The research and the linked mutations are frequently being updated based on what we know. However, for these other familial cancers, it might be a shared environmental risk, shared exposures, that's leading to increased cases. However, it's really important to understand who has these hereditary mutations. So a number of screening tools have been developed and are based on NCCN guidelines to identify individuals who might be in need of genetic testing to see if they have one of these hereditary mutations linked to specific cancers, genetic counseling, and then ultimately tailored screening guidelines. So what age they should start screening, what cancers they should be screened for, and some other medical management interventions may also be recommended. So that's based on their family history and hereditary syndromes. And the most common hereditary cancer syndromes are Lynch syndrome, which, as I mentioned before, has a really strong colorectal cancer linkage, but is also being linked to some other cancers as well. And then hereditary breast and ovarian cancer diagnoses. For both of these syndromes, many patients who have these syndromes are more likely to be diagnosed with these cancers at an earlier age. However, just having one of these hereditary cancer syndromes does not mean the patient is definitely going to develop cancer in their lifetime. And with earlier screening, that can really help prevent cancer from developing in those who are at higher risk. So through our capacity building work, we're really supporting clinics with creating these workflows and processes to get their patients access to genetic services, that are genetic counseling and testing. And right now partnering with Ambry Genetics, using their chatbot tool and linkage to genetic testing and counseling services. However, there are a number of labs that do genetic counseling and testing. And in addition, CCSP also does have our family history screening tool, which was developed with our medical advisory team, a lot of genetic experts across the country. And that tool can also be used when a patient has a yes to any of those questions. It means they're a candidate for genetic counseling and testing. So we have one more poll focused on hereditary cancers. So which of the following statements are true about family history of cancer? And I think you should be able to select more than one response. All right, we'll give it about 15 more seconds. Still getting responses in. All right. Slowing down. So the responses were having multiple relatives with cancer is more concerning when they're on the same side of the family. Yes, that's true because it's showing those that are blood relatives are passing or all having cancer. So that could be due either to environmental risk or a hereditary cancer syndrome. Lynch syndrome is the most common form of hereditary colorectal cancer, but it can also be associated with several other cancers. And then the last one that is true is an estimated 95% of Lynch syndrome cases are undiagnosed. So this is really important because for that increased incidence of colorectal cancer in younger populations, Lynch syndrome is really connected to hereditary colorectal cancer and higher risk at younger ages. Not all of the increase in earlier age onset colorectal cancer is due to Lynch syndrome, but it's definitely a contributing factor. So it's really important to get those patients identified, others in their family who might have Lynch syndrome, so that they can all be following an appropriate screening regimen and prevent colorectal cancer. And then all patients with a hereditary cancer syndrome will not ultimately develop cancer in their lifetime, especially if they're following those screening recommendations and medical management recommendations that are appropriate for their hereditary cancer syndrome. However, they do have a much increased risk and they may develop cancer. Next slide. So I'm now going to turn it over to Wesley for our section of the patient navigation basics. But these can be applied to colorectal cancer screening navigation, as many of these components can be also applied to navigating patients through lung cancer screening, as well as hereditary cancer risk assessment.
Awesome, thank you. All right, so I'm going to talk about the role of patient navigation and go into some detail on the different components and themes of what a strong patient navigation program entails. But I'm really curious to hear from other folks when prompted on different things, and if we can maybe share some best practices or some learnings with other people on the call, because really you all are doing the work and you're the experts. And I'm talking more here about the theory, but love to hear more and better examples of how this plays out in practice, including some of the pros and the good things that happen, as well as some of the challenges. And maybe we can think through overcoming some of those today. So patient navigation essentially assists patients across the cancer continuum of care. It decreases patient anxiety associated with medical services. It reduces barriers to cancer care, improves access to healthcare services, enhances quality of care that patients receive, promotes continuity of care, and increases patient follow-through and satisfaction with healthcare services. And this is a really pivotal component of any strong colorectal or lung cancer screening program, is having a strong patient navigation focus, especially for the different populations that you all work with. Having that warm handoff and that guidance is really beneficial. Like Andy had said, really improving the prep rate and really getting people engaged and understanding of their care and why this is important. So a really important member or function of the medical team. So I had mentioned this workflow at the primer, the CCSP 101, but essentially we'll go into a lot more detail and deeper dive of these components today. But the basics are a patient navigation program includes in-reach and outreach, education, communication with primary care clinics, with specialty clinics, with the community, barrier reduction, so identifying those barriers, working to link patients to resources that help with those, and overcoming those reminders. So as Andy had said, those reminder calls are really important, understanding who's responsible for what reminder, things like that. Care coordination, so making sure that all the paperwork and components and everything is organized and available and documented. Determining insurance coverage, so knowing who on the team is responsible for this, and then data collection and reporting specific to the CCSP program, which Elsa will go into more detail on at the end of the training today. So I had sent out the patient navigation roles and responsibilities checklist last week, just as a prompt and primer for you all to think about who is responsible for this specific activity, and or if it's not in your organization, if it's with a partner organization. Always helpful to kind of go through this and reevaluate your workflow, kind of identify where there may be some hinges that need some oiling or some things that need to be clarified. So I'll go through each large section, like the theme, and then I'm curious to hear one or two folks or anyone who wants to chime in with who's responsible for this and where you're from and how that's working. So as far as in-reach and outreach, these primary activities are really identification of clinic patients in need of screening, contacting and educating eligible patients about cancer screening, and then educating individuals who are current clinic patients as well as the community the clinic serves about cancer screening. So curious to hear some people how this workflow is going, any lessons learned, challenges, benefits, things like that. So does anyone have any insight on their in-reach and outreach work within their patient navigation program? And I put everyone on mute, so if you want to talk, you might have to take yourself off mute.
Hi, this is Victoria with Guadalupe Health Center. I find usually that for me, and it's not all the time, but I like when I know that they're going to be referred. The day that they're in here, if they're referred for a colonoscopy, I like to meet with them and let them know like what to expect. I think a lot of what helps patients, like when they have anxiety, like, oh my God, they want me to do this referral, they want to send me for this, is a lot of times because we are integrated with behavioral health. If their anxiety is that bad about it, I walk them over to the behavioral health just to have them meet with them and let them know, tips to lower their anxiety or treat that. And then we just stay in touch with them, like help schedule the appointment, the reminders and whatnot. And if they feel if they feel the need for anything, they feel more comfortable calling. But I like to get them when we know, like the day that they're going to be referred. For me, is easier because that way you get to see them face to face. You're not just on the phone.
Awesome. Yeah. So catching them in there, and really, it sounds like you have a really strong, warm handoff going on with behavioral health if there's any sort of increased anxiety or reluctance. So yeah, that sounds really good. It sounds like you have a strong relationship and workflow going on there. So thank you for sharing, Victoria. Okay, I'll move on, but if you had anything in any examples that people want to share later that refers to in-reach and outreach, go ahead, just because Victoria hinted on some of the other things that are in here of, providing that education and care coordination. So it's all really intertwined. So if you, I'll go through and then, yeah, if you have any insight, love to hear it. So as far as education, explaining the screening procedure and its preparation to patients, ensuring they understand the screening process and necessary preparation, explaining the anatomy of the appropriate bodily systems, and then emphasizing the medical need for the screening method. I think in here as well, it's talking about prep and all the sort of clinical components of this, making people understand what the different screening procedures entail, things like that. So if anyone has any insights from their education component of their navigation program, happy to hear those.
this is Laura, and kind of piggybacking on what Victoria said with regards to in-reach and outreach. When we identify the patients, we usually do that in our morning huddles. We have a list of patients coming in, and on that huddle, we have a registry of items or screenings that they're requiring. So with explaining the screening procedure, I'm thinking that that would be part of here in the San Luis Valley, we refer to our general surgery department. And when they have that consult, I think that's the perfect time for those providers to share that education with the patients. And then in following up, when we, call them to let them know we're going to navigate them through the system, ensuring they've got their consult scheduled, again, we can provide that education, because I think the more they hear it, the more they absorb it.
Mm-hmm. Definitely.
I think it's good to kind of have the little visual, the map that I can't even talk, sorry, that Andy showed us earlier with regards to the stages, the progression of the polyps. If we can show them that, and then the anatomy of how the colonoscopy is going to proceed, the scope's going to proceed through your body, they will have a more, at least an idea of what's going to happen, and they can hopefully ask questions and maybe not be so concerned about getting it done.
Mm-hmm. Yeah, great. Thank you. Yeah, so having that open communication and the multiple touch points, very important. Okay, so the referral and insurance coverage, also a very important component of navigation. As Elsa and Andy have mentioned, just knowing what is covered by different insurance, what they have available, if they can apply for different financial assistance programs. This is all important to capture this information so that we know this. So the roles that would happen in this, the responsibilities would be facilitating and ensuring the appropriate screening, referral, or order is completed, verifying patient income and insurance status per your clinic policy, and helping patient apply for financial assistance programs such as Medicare, Medicaid, or SSDI. So any thoughts or best practices that you all have to share about the referral and insurance coverage components?
And in some clinic systems, there might be different people who are responsible for assistance with enrollment in insurance and financial assistance. So if that is the case at your clinic system, if a patient needs assistance, I think having those relationships and understanding what they can do, what they can't do, can be really helpful as well. Some hospital systems have specific financial navigators. So if you're referring a patient to a hospital to get screened, sometimes there might be opportunities to make connections with those people that the patients might need to speak with as well. And understanding what they can cover and what they can't do, it can be really helpful as well.
Thanks, Elsa. I'll move along since that was a good example, but if anyone has any thing else to refer to that, I think there's one more slide that touches on that. So if you think of any best practices or challenges you'd like some insight on, feel free to say that. So going through barriers, I know this is something that comes up frequently with navigators, is that ensuring that patients have transportation to and from screening and supportive care after, working with patients to overcome different barriers related to education or financial, logistic, language, transportation, and utilizing those motivational interviewing skills and resource directories that we have a lot of resources for, and some people may or may not have completed trainings on, but really applying the tools and resources to overcoming barriers. So does anyone have any quick thoughts on how they identify patient barriers, who's responsible, some sort of best practices or challenges in overcoming these?
This is Laura again. In our organization, the barrier reduction is going to fall on the shoulders of the patient navigators or case managers.
Great. All right. I'll go through these last three and then allow a little bit of time for anyone to provide any insight on this page, and then I'll move along, just so that we keep on track and I don't have to make you all talk too much. So just reminders, those are placing the reminder calls before the screening appointment to decrease no-show rates, utilizing the reminder system through your EHR for surveillance and annual screening, and a lot of the evidence-based interventions that Andy briefly touched on at the end of the CRC screening best practices really are there to improve surveillance and annual screening and identification of patients. So those are some things to use if they're not already incorporated into your program. For care coordination, this is, ensuring those cancer screening results are delivered to the provider regardless of findings. So having a good working relationship or liaison between providers and patients, and additionally between providers and providers. I know that we hear often that it's difficult to get that bidirectional communication from the specialty care to get the medical records that they need. So just having a good working relationship and really honing in on that workflow can be helpful. Following up with patients to ensure they understand the exam and test results and when they should be rescreened, or how to access additional care. I will put a little plug in here, and I had mentioned it in the email, that we have an oncology navigation nurse coming to our monthly meeting tomorrow to talk about what she does as a GI oncology navigation nurse. So working through the patients if there is a diagnosis of cancer and what that looks like on her end. So I think it should be really interesting to see how best we can link up with those folks who are doing that work on the oncology side. Assisting patients with setting up appointments for follow-up care, informing patient who the primary contact person is if there are questions, and knowing who to contact if there is a cancer or adverse event. And then the last bit is just those program reporting and training activities. So collecting data points for evaluation. And I believe we've had conversations with folks about what sort of data points we're having for the evaluation. But knowing that you have the no-show rates, the appropriate prep, completed the follow-up, etc. Also, we'll go into more detail. Maintaining files on patient-specific data and records for audits, providing us with monthly colonoscopy navigation and barrier reduction invoices, and then attending trainings and TA sessions, participating in skill building opportunities. So does anyone have any things to add here for roles and responsibilities for patient navigation within your clinic? Anything that you might do that's maybe above and beyond this? Because I know that there's a lot of people who are doing this work plus others. So yeah, curious to hear some summary thoughts here before I go into a little bit more of the in-depth best practices for these.
Hi, it's Victoria again, and Laura, correct me if I'm wrong, but the care coordination still falls on the case managers because we don't pass off the patient if any of this happens. We are the ones who do the follow-up, correct?
Correct. However, most of my team, well, all of my team, I don't have any clinical, they have no clinical background. So if there is a definitive diagnosis of colorectal cancer, that's going to be either their primary care physician or nurse to provide, or the surgeon to provide that diagnosis.
Yeah, that's not within the scope. All right, Elsa, anything else to add here before I move along?
I would just say if your clinic system hasn't filled out what the roles are for everyone for each of these services in the last year or so, I would definitely recommend, if there's an opportunity, to huddle as a team and make sure it's spelled out who's doing what, especially if there's newer members on your team, or if you're a newer member on the team and have questions about who's doing any of these roles, checking in with your supervisor to make sure the full range of navigation services are being provided to patients to really improve their quality of and understanding of the cancer screening process.
Thank you. And then we'll send out the slides, but there are links in here to different navigation resources and competencies that this is somewhat adapted from. And then also existing trainings and webinars that have happened before, if you're interested in going through a deeper dive or walking through this.
And the last thing I'll say is Wesley has been taking more of the lead on the training and technical assistance. So in any of our upcoming calls, or if you all want to schedule a call, we're happy to help support your clinic system with walking through this and facilitating a conversation with your team if he does let us know.
Thank you. Yep. All right, so just inReach, outreach, and education, going over the goals and different topics here. So that really these three are to increase the awareness and uptake of the screening services. inReach is more thinking about that, identifying your current clinic population who is eligible for cancer screenings. The outreach is more thinking in terms of awareness in the community. So getting out there, talking to people, not necessarily within the confines of the clinic. And then the education topics are those that Victoria and Laura had hinted on that are, really going over the details of what the medical need for the screening is, what the methods are, explaining the anatomy, explaining the procedure and necessary preparation, wherever that makes the most sense within your workflow and policy process, and to the degree that the patient knows or does not know. So important to explain in detail and then go over in additional detail any other sort of misgivings. So I really love the idea of the warm handoff to behavioral health if there's any need for additional support or things like that. And again, we have a link here to different materials that have already been created. So no need to reinvent the wheel if you are in need of some new materials. Talking through some communication essentials, just because so much of this is important in how and when you're interacting with patients in what can often be a sensitive topic. So motivational interviewing is one of the guided communication styles that we like to provide trainings on and enforce, and really, give this benefit of how we can provide this engaged conversation. So this is a client-centered guided communication style for enhancing a person's own motivation to change. And this has been used a lot with smoking cessation, but now it can be adapted for all sorts of different medical needs. So it applies these techniques to assist clients with working through barriers to behavior change. So there's 4 processes here: engaging the client, focusing on their primary needs and concerns, evoking internal motivations for change, and then planning. So creating a plan for change. So these can be really important, especially if there's someone who has some holdups or misgivings about wanting to complete a cancer screening, really meeting them where they're at and using the ORS technique, which is open-ended questions, demonstrating interest, providing affirmations, so statements and gestures that recognize their strengths. So not providing, heavy judgment here, but listening, highlighting their strengths, highlighting that, there are valid reasons to be concerned about his, and here's how we're going to address them. Reflective listening, so just repeating and reflecting back their words to demonstrate that you've understood, and then summarizing the information from at reflective, or summarizing what you've learned at different transition points in the conversation. So applying this, there have been trainings, it's in the guidebook. There's some modules from the Patient Navigator Training Collaborative that we've linked here that can be helpful in understanding and practicing and applying this with your conversations with clients. So really important and neat tool to provide that active and reflective listening. Some other tips this is from the University of South Carolina and their colorectal cancer prevention network, just for engaging the patient. So finding a motivating factor, creating a trusted environment, addressing fears and concerns, not letting their comments catch them off guard, and providing, a warm, smiling environment for them, just like I said, because this can be a sensitive or embarrassing topic for some people. Helping to overcome the ick factor that some people might have with colonoscopy or FIT. So addressing those prep fears, addressing what the process is going to be like, any embarrassment people may have. For FIT, they have recommended, providing gloves with the kit, explaining that people are not touching it themselves, and enforcing again that it's an easy at-home screening test. So, explaining that, it can be kind of weird, but this is important and this is why we should get it done. And then constant reinforcement. So some people are still gonna, say, no, I don't want to do this. So you go back to those motivating factors. Why is this important? Why would it be important to find a cancer early? Repeat messaging that enforces this importance to patients. Recommend screening regardless of insurance status, just because even if folks are uninsured, there are resources. Some cost money, some do not, working on creating, some linkages to a more comprehensive and robust program for that. But especially for FIT programs, recommending screening regardless of insurance status, and then readdressing at the next visit if a patient declines screening. So this is really important that you have those eligibility and surveillance mechanisms built in so that you know who's due, who might have said no last time, and if we can maybe talk to them again this time, explain it, see if anything's changed over the course of the past year, 6 months, or however long it's been. But really just reinforcing and readdressing those misgivings. So having everyone in the clinic be encouraging, laughing, providing assurance and support, addressing concerns and barriers, having staff available for questions, and then a clinic process for follow-up with the patient. So these are all different things that tie into having a strong navigation program, even if it doesn't go, yes, I want this screening. So there are things to do to overcome potential no's and engaging the patient, and so important in working with them where they're at. Another thing that people are going to say no, they don't want to do this, are some barriers, and these are very real barriers. So having these barriers, one, identified, and then helping find solutions for different types of ones, especially ones that are pretty common and come up fairly often. We do have a limited barrier reduction fund to support colonoscopy lab navigation. But again, you want to make sure that you're, one, screening for barriers so that you know to address them, and then two, having resource directories or resources on hand that can address these barriers. So basic needs, there's 211, there's the resource fair directory, health literacy, just making sure everything is culturally informed, utilizing motivational interviewing techniques and client reminders in patients' primary language, financial and costs. So assisting patients with enrollment for insurance and or financial assistance programs. We've mentioned colonoscopy assist. The Colon Cancer Alliance also has some financial assistance programs that I know that we've updated the resource directory with. And there's an entire section that's financial assistance programs that we will continue to share if we identify any new ones, because I know that this is a point that becomes one of the yes, no moments. Like, do we have enough money to complete a colonoscopy, especially if it's for someone who's uninsured or diagnostic, which can be a fair amount of money out of pocket. Language, utilizing small media materials in their first language, and arranging for interpretation services as needed. And then transportation. Not that they can use public transportation if they're going for a colonoscopy, but providing vouchers or gas cards if someone has to travel to another location to get screening done, helping to identify if patients have someone that's going to be able to drive them after being sedated. So things like that. So knowing if they have a support system and if they have the means to get to where they need to go. There is a barrier and needs assessment template that we've created that you can use to help identify barriers and provide them with solutions. And then determining insurance coverage. So as was mentioned before by Elsa, this will differ by clinic. Some clinics have their own financial assessment programs. Others are a little smaller. So it varies based on who's responsible for this, but knowing who will help enroll patients in insurance programs, reviewing coverage and benefits. I know that we'll send out some language to the group at large to say that 45 to 50-year-olds will be covered on all Colorado insurance starting January 2023, because I think this is a really important thing to highlight, that group that was kind of maybe iffy on coverage before is definitely going to be covered within Colorado, and how important that is for folks to understand if that had been a holdup before. Identifying any copays or additional costs that might come up as best you can. Sometimes you don't know how much it costs until you receive a bill, and that's really difficult to estimate for, but there are ways, if you know copays or different benefits within the insurance program, that you can inform folks on that. Or if they have a high deductible, talking about the realistic costs of what this might look like. And then determining if patient is eligible for CCSP navigation reimbursement. So as Elsa mentioned at the very beginning of this, there are different eligibility requirements for CCSP navigation, essentially 400% or below of the federal poverty line, and then all sorts of things. Most insurances or all insurance status is covered, and they just need to be eligible based on the medical guidelines. And then reminder and care coordination, just checking the time here. I think we're good. So assist with appointment setting, reminder calls, just making sure that these confirm the date, time, location, directions, that they have transportation, that you've worked to overcome these barriers, and that they have the proper prep procedure. If that's you, or if that's the surgery center or folks with the specialty center that are doing that, just making sure you know who's responsible for what with different areas is really important, just so there's not any one conflicting information, just because prep can vary from site to site, and two, that patients know what they need to do, know who's responsible, and that they're not getting bombarded with a million phone calls. And then following up with patients about the results of the procedure, regardless if it's abnormal or normal. So people want to know what happened, what were the findings. This can be where you're the liaison between patients and providers, and then understanding the results and knowing when they should be rescreened. So, oh, this is normal, we'll see you back in 10 years for your next colonoscopy, or, oh, you had a positive fit, now we're going to refer you for colonoscopy, and investigate that positive further. So having the patient understand what the next steps are. There are some limits, just hinting at here. The patient navigators do not provide direct hands-on patient care. They will not be providing physical assessments, diagnoses, or treatments. So if there was a finding of cancer, that's left to the surgeon or the primary care doc, someone with clinical expertise. There's no way to offer, it's outside of scope to offer opinions about a diagnosis, treatment, or healthcare service. Do not provide or give information about treatments other than the approved basic information from medical sources. And it's beyond the scope to generally give money to patients, personally drive patients to and from appointments, and personally visit patients in the home. So just ensuring you're familiar with and following the policies of your organization. Like I said, these will vary by site to site, but knowing what you can and cannot do, and understanding, how important this role is within team-based care, and creating a robust screening program, and how important this role is in the screening and prevention of cancer process. And then just a real quick, I think sustainability of patient navigation practices. So I know a few folks are working on capacity building and then also sustainability. So when we talk about sustainability, we're really talking about the ability of an organization to maintain structured clinical care practices over time and to evolve and adapt these practices in response to new information. So grant funding and support ebbs and flows. How well is the program going to function if some of that funding is restricted or pulled or lessened? Or if there's a new kind of program or funding stream, how can we adapt to that? But knowing that there are some core components and domains that are important to ensure that a program that you set up is sustainable. So each clinic system has assessed sustainability capacity and developed a goal using the Patient Navigation Sustainability Action Tool, the PNSAT. Examples of activities supporting sustainability are that your job descriptions with key roles and responsibilities highlighted in them. So it's clearly defined who is responsible for what components of the patient navigation process, ensuring that the navigator role is clearly documented in clinic workflows. So know when people are being referred to the navigator or people who serve those navigation roles. Revisiting these needs and capacity in 2023. So we will help with revisiting those next year. And then state and national efforts to support sustainability through reimbursement and quality metrics. So understanding ways that clinics can get additional funding or reimbursement through meeting different quality metrics. So here just highlighting the different domains and what those are. So having engaged staff and leadership. So having people who are supportive of patient navigation, organizational context and capacity, that the practice has the internal support and resources needed to screen and navigate patients and clients. Funding stability, that you've established a consistent financial base, having an engaged community so that the practice has external support and engagement beyond just the clinical navigation team, communication, planning, and implementation. So using processes that guide the direction, goals, and strategies of the process or of the practice. Workflow integration, so designing the practice to fit into existing practices and technologies. So this is thinking about how you can incorporate different workflows and metrics, and tracking into EHRs or existing workflows. Monitoring and evaluating, so assessing the practice to inform planning and documenting those results, and then outcomes and effectiveness, so understanding and measuring practice outcomes and impact of the practice. So essentially that you have engaged folks both internally and externally, that there's funding stability, that you have a clear process and workflow, that you're working with existing systems, and that you're tracking the metrics that make the most sense for demonstrating successes of the patient navigation program within your clinic.
And real quick on sustainability planning, I'll just add that we know, as I mentioned before, we're in the last year of our current funding cycle for CCSP. We're waiting to hear from CCPD about whether CCSP will continue to receive funding from them for colorectal cancer screening work. So no matter the outcome of that, we're going to meet with all clinics sometime in the second half of this fiscal year to really revisit your sustainability goals one more time and think about current sustainability capacity as we move into this next iteration of the program, no matter what that looks like, to make sure you all, we're providing you with resources that are existing, thinking about what still needs to be focused on internally to help support patient navigation and making sure that seems sustained. However, we've heard from many of you that overall things are looking great to sustain the patient navigation practices, and really thinking through this capacity has been helpful to do that. So we're not going to make clinics go through the long version of the PNSAT again, but we might be using an adapted version just to think through one more time what's changed in terms of capacity how we can link to resources, and if we're not refunded, making sure we're connecting clinic systems with other resources for continuing your patient navigation and colorectal cancer screening programs. We're very hopeful though, so we'll let you know as soon as we know anything about the funding.
And before I do the last calendar of the training and technical assistance webinars that we have upcoming, I wanted to take a moment to pause here and see if anyone had any thoughts or questions on patient navigation for cancer screening that they'd like to share before moving on. I know that it's been a lot of talking on my end, so wanted to hear from folks if they have any questions or barriers that they'd like some thought or insight on from other folks who may have encountered and overcome those. Really just an open-ended question here at the end of the patient navigation section.
Or best practices
Yes.
that have worked really well for you.
Yeah.
I had a question. I'm sorry, there's two of us in one office, so you get all the static. So I had a question on the funding for the CCSP navigation, the 400% for the federal, or however that went. So I have some patients who have no insurance, and so they declined their colonoscopy because of funding. And they either have a positive FOBT or a positive Cologuard. So I have tried finding ways on trying to see, well, maybe the office will do a payment plan with you, or just basically that's it, because I don't know any other ways to have them do their colonoscopy besides the payment plan. But when you had said that the CCSP navigation would help pay, I wasn't exactly sure what that meant besides that.
So are you asking about the line here that has the limited barrier reduction funds?
I can't hear you.
Oh, am I? So the section here that has the CCSP limited barrier reduction funds, is that what you were wondering about?
Yeah, I think Wesley, how about I'll take the first piece of this and then you can fill in if you think there's anything in addition. So CCSP is only able to reimburse the clinic directly for navigating patients into colonoscopy. So once they successfully are able to attend that colonoscopy and receive those navigation services, that's for anyone at 400% or the poverty level, but the reimbursement goes back to the clinic per person navigated into colonoscopy. Unfortunately, with CCPD as our primary funder, before the Affordable Care Act, CCSP was able to directly pay for colonoscopies and treatment in some cases for patients who were uninsured. Unfortunately, since the ACA passed, which in some cases was really helpful for expanding access to insurance coverage for patients, but at that point, CCPD has no longer allowed CCSP to directly pay for the direct medical services, including the cost of the colonoscopy. So at this time, there are hospitals with individual payment plans, sometimes a reduced rate. The National Colonoscopy Assist Program exists in Colorado and also has connections with providers who offer a discounted rate for colonoscopy and the pathology services, all of the services connected to a colonoscopy, one flat discounted rate. However, that is still definitely expensive for many, many patients. We recently learned about the Colorectal Cancer Alliance's financial assistance programs, but have not personally yet heard of people using those. However, they do have some funding apparently for colonoscopy assistance. And then Wesley and Andy are part of a group in Colorado that's trying to build connections for pro bono or in-kind free and really reduced rates for colonoscopy. So that's still in the stages of being built. Unfortunately, that we 100% acknowledge this is a huge barrier in Colorado and are really trying to better understand which providers in the state are offering low cost or no cost colonoscopies to patients who don't have insurance. So we're always looking to hear from all of you as well, if you hear about any sources for assistance in this. And sometimes the Colorectal Cancer Task Force of the Colorado Cancer Coalition is able to arrange single days where they have a provider or two that's doing free colonoscopies. That is something they were able to do last March, I believe, but they are still working on planning the next event. So I think some of our Sunrise partners were able to connect patients to that resource. And as soon as we hear about another one of those free colonoscopy days, we'll let people know as well. Wesley, anything else to add with that? And Isabel, did that help answer your question?
Yes, that did. And then also, when you have your free day clinic, will you let us know? Because I have some patients I'd really like to get set up for that free day.
Yes, so yeah, that gets arranged by like the Colorectal Cancer Task Force and the American Cancer Society. So as soon as we hear from them that another one has been set up, we'll definitely let people know.
Thank you so much.
Yeah, and that's a great question, because I think that this is the really the transition point of, is a patient going to follow through with this or not, because it's so cost prohibitive. So this is the challenge that we keep coming across. So I'll send out a link with the follow-up email to Colonoscopy Assist and the Colorectal Cancer the Colon Cancer Alliance Financial Assistance Program. And then just wanted to tag on to Elsa saying, we know this is a problem. We're really trying to figure out how best to support this and create a statewide referral system for low or no cost colonoscopy. And then if we hear of anything, we will be sure to share with the group. And then also the American Cancer Society has they're moving forward with a grant or have grant funds to address this issue as well. So it's coming, we're working from a lot of different ways to try to identify some ways that we can get these essential screening services or diagnostic services to the people who need it most. So thanks for highlighting that. That was a great question. One last point before I give the floor to Elsa. Wanted to highlight that we saw this at the primer. We have a lot of training and technical assistance that's upcoming. So wanted to go over, I was bombarding everyone with calendar invites the week of Thanksgiving. So thank you for responding to those. But wanting to get this all on the calendar because we do have some great trainings coming up. So we're here, we're in December, but in 2023, we have different focuses for our different monthly meetings, and then some additional large trainings or in-person meetings maybe towards the end of the year. But want to highlight that we have someone from St. Jude's talking about cervical cancer screening and HPV at our January meeting, and then additional motivational interviewing and health literacy training. We're going to have someone from CCMCN, which is one of the Colorado technical assistance programs for EHR support, to come talk about EHR utilization, evaluation, and data monitoring support in February, with a focus on population management programs and some best practices related to how to use your EHRs to identify patients and move through those workflows. So I think that'll be really interesting. March, we're really setting up a great 2 or 3 hour panel on policy and critical issues in colorectal cancer screening. So folks from Fight CRC, which is a national advocacy nonprofit, some folks talking about potential multi-component cancer screening. So I think that'll be really interesting. And I put that on everyone's calendar, and we're going to open it up to folks in the community who will be interested. We have some trainings related to workflows and assessing sustainability for current and future state. And then as we move more into the year, we'll put some additional trainings on your calendar for thinking through comprehensive cancer programs and survivorship. So I wanted to do one last poll before I check the chat. Okay, so one last poll of really, do these training and TA opportunities match your needs? It's just yes, no. If not, please send me an email of what you'd like to see or have covered. And we can see how we can incorporate that. So let me try to open the poll. I don't know why it's not letting me. There. So really just taking insight from the evaluations that we've received and really wanting to get on here and address everything that you have questions about.
And if you are already thinking of other ideas that would be helpful, feel free to put them in the chat here as well.
Yes. And even if these meet your needs, feel free to shoot us emails at any time if you think of something else that you feel like you'd like to learn more about related to cancer screening, because I feel like we, Andy especially, is very connected to knowing who good resources are, and Elsa. All right, so looks like we're seeing a lot of people saying that, yes, these are meeting your needs. So that is good to hear. Just so people aren't surprised at the end of this presentation, when you click out of the meeting, it's going to prompt you to go to a survey just to provide some feedback on what you learned today, so we can always improve. So wanted to preface that here because that does help us with training and technical assistance opportunities. So yeah, really appreciated that and all the work that you're doing on patient navigation and all the great supports that you're providing patients. And then if you are continuing to meet with different barriers, like we know about the cost prohibitive issue with people who are uninsured or any other things that come up, just let us know and we'll see if we can match you to different solutions. So yeah, I think that's all I have here for patient navigation. Elsa, do you have anything to add or any last comments from the group before we take a 5-minute break?
I think you definitely covered all of the main components, and yeah, as Wesley noted, feel free to let us know if there's anything we can support you with your patient navigation practices. So we're in the final stretch, final 45 minutes of our training. So thanks so much for sticking with us to this point. We're going to have a 5-minute break, and then we are going to move into the last piece, which is again a review of our the colonoscopy navigation monthly report, as well as the billing for the colonoscopy navigation work, since those are most clinic systems participating in CCSP are doing the colonoscopy navigation work. So if you're not a member of CCSP, if you're interested in learning about endoscopy and pathology reports, it's has great information about that. But otherwise, if you're not currently participating in the colonoscopy navigation work, you're welcome to jump off after the break or at the break. But we'll have 5 minutes, so come back be starting again at 3:20. And then we have our last section and activity on interpreting those endoscopy and pathology reports. So thanks everyone, see you in 5 minutes.
Thanks, Elsa.
All right, so we're right at 3:20. So we're gonna go ahead and get started in our last section for today. But before we get started, if you did not take a chance already to stretch, or even if you had, I'm gonna invite everyone to do one last big chair stretch before we move into this. We'll wake up. Okay, I needed that too. All right, Wesley, are you ready to move us on to the next slide? Okay, so our last section, as I noted, is the colonoscopy navigation reporting. The full written guide is available on pages 76 through 85 of the program guidebook. And we also have more resources on the CCSP website. But we're going to expand upon our brief review of this section that we went over in October, go through it a little slower since I know last time we really had to rush through it. Next slide, please. So just taking a quick step back, CCSP has some overarching evaluation questions that all of our evaluation efforts for the program seek to help answer. So these include: how does health navigation impact health outcomes, such as access to services and screening rates for preventive cancer screening? How well were patient barriers to preventive cancer screening identified and addressed by health navigators? What training and technical assistance is needed for clinics to develop and implement navigation workflows for colorectal cancer screening, lung cancer screening, family history screening, and aligning with breast and cervical cancer screening? And lastly, what is the capacity for sustainability of patient navigation for cancer screening at clinic systems participating in the program? So we definitely try to be mindful of the evaluation reporting burden for all of our clinics and reduce required elements where we can. But these are the questions we're seeking to answer in all of our evaluation efforts. And it really helps for CCPD. They're really curious about these questions to demonstrate impact and reach of the program activities. So every piece of evaluation we've had you all do for CCSP has been connected to these questions. Next slide, please. So the one of the most major pieces, of course, is that monthly colonoscopy navigation report, which is required for all clinic systems that are invoicing for reimbursement of navigation of patients into colonoscopy. And so we collect aggregate data monthly from all participating clinics on patients that were navigated into colonoscopy. So this is not the patient level data, it's counts for each of the evaluation questions. I've linked the monthly evaluation report in Qualtrics. This is the report link we're using for this full fiscal year. So from July 2022 to June 2023, we ask that you submit your report by the 10th of the following month. So for example, the November report is coming up due on December 10th. So December 10th, asking for the report of all of the patients that were navigated into colonoscopy during November. We know sometimes, however, reports or results from patients might be delayed, or things come up and you might need to submit it a couple days late. If you know you're going to be delayed, just please let me know in an email. But we can be pretty flexible about it, except for the last report of the month, because we have a very strict end of year deadline from CCPD for both the evaluation reporting and the billing. But we provide lots of resources to try to help with preparing you with everything you need to know to collect all the information for the report. So these trainings, tracking tools, and also just assistance with quality monitoring, making sure the data you're submitting looks to be correct and complete. So we check for any discrepancies between the billing and evaluation numbers, and have had all clinics do some audits of their data. But if you're participating in the capacity building activities for stool-based testing, colon cancer screening, and family history data, that is collected not on a monthly basis, a little less frequently, and sent directly to me. So we've worked directly with each clinic system to select metrics if you're participating in those activities. So it's a little less evaluation burden, but still really important. And for all of the work that you all do in this area, we really want to make sure you receive that information back. So we synthesize and disseminate the summaries of results back to your teams annually, both for your individual clinic system as well as the program overall. Next slide, please. And this is just a quick screenshot of the tracking template that's provided for clinics to track their patient colonoscopy data. In order to synthesize all of the information and then report it at that aggregate level, the tracking template allows you to look at the evaluation data at that patient level and then sum it up for those aggregate counts. And the aggregate counts are what ultimately are reported in that online Qualtrics report. So this tracking template by month has all of the data metrics that are reported and will allow you to track a patient through that colonoscopy navigation process. So once you know that a patient has been referred for colonoscopy, they're CCSP eligible, can put them in this tracking template, track whether they scheduled their colonoscopy appointment, when it is, if it was needed to be rescheduled, and then ultimately, were they successfully navigated into colonoscopy? And successfully navigated for CCSP purposes means that they did attend their colonoscopy appointment. So even if you're providing navigation services to patients that might not meet the CCSP eligibility criteria, for your own internal purposes, you can have them on this spreadsheet just for the initial stages of navigation. But then for all of the demographic and outcome metrics, we only need those for those CCSP eligible patients. So looking at colonoscopy appointment attendance, it's only CCSP eligible patients, and then all of the demographics and outcomes are only those patients that showed up for their colonoscopy appointment. So we'll go through an example in just a moment, but just wanted to kind of orient everyone to this tracking template. And you don't need to submit your tracking template with the monthly report, but it is important to be tracking that patient data in case any questions come up about what was submitted in the reports, and as we're having clinic systems do annual data audits. And this year, if you did an annual data audit in FY 2022, you won't have to do one this year, but we had half the clinics do one in FY 2022, and we're having the other half who did not do one last fiscal year complete your annual data audit this year. But either way, still really important to be tracking this patient level data to make sure it's complete if there's any questions that come up. Next slide, please. So here are actual screenshots of how the report looks in Qualtrics, where you're just entering in those aggregate level numbers. So first it'll just ask who's completing the report, your contact information, what month it's for, and the clinic system. But then really starting with question 6 is starting to collect that patient data. So the first question is really looking at how many total patients were successfully navigated into colonoscopy during the report month. And initially that total number, so the first part A, was total patients successfully navigated into colorectal cancer screening with colonoscopy. or could be another visual exam, but we say colonoscopy. And successful navigation, as I mentioned, means the patient must have attended their colonoscopy appointment. So if you were navigating any patients that are not CCSP eligible above the 400% of the federal poverty level, you could still indicate how many people you were able to successfully navigate with this total number. And then the second part is how many were actually CCSP eligible who successfully attended their colonoscopy appointment. And the second part, the CCSP eligible patients, it's really important that you get this number correct, because all of the questions moving forward will make sure that it adds up to this total number of CCSP eligible patients who are successfully navigated into colonoscopy. So this should also match the total from the appointment kept space, as well as should match the number submitted to billing for reimbursement. So any cancellations and no-shows, we definitely want to track those, but they don't fit into this number of patients successfully navigated into their appointment. But this question 7 is really breaking that down further. So from this point only, it's only looking at CCSP eligible patients. How many did keep their appointment, that successfully navigated number, but also how many had a cancellation that wasn't rescheduled during that current month, and how many patients were ultimately a no-show for their appointment. So a no-show means they didn't call, they didn't notify anyone that they would not be able to attend their appointment. So day of, they just did not register their appointment, which is separate from a cancellation. And navigation, making sure that patients are aware of all of the needs for their appointment, that preparation, overcoming barriers is really hoping. What we like to see is that it's driving a reduction in no-show rates, even if there are still some cancellations. So we really highly recommend that patients or clinic systems have a process in place to track those no-shows. But really, we want to know how many patients attended their colonoscopy appointment. Next slide, please. So I'm going to pause just real quick and make sure I didn't miss any questions. Okay, I think we're good, but again, please feel free to stop me if any of this is unclear, because it can be a little bit nuanced with making sure understanding the definition for these metrics. So next, moving on to the demographic and patient characteristic metrics that we collect in the report. So those are gender, age, race, ethnicity, and insurance payer. And as I noted, so on that previous slide, the number of CCSP eligible patients who were successfully navigated into colonoscopy was 30. 30 patients were at or below 400% of the federal poverty level and did attend their colonoscopy appointment. So all of these demographic and characteristic metrics should add up to that total of 30. And it automatically validates your answers. So it's checking in the report that it does add up to that total. And if it doesn't, it will be a red number in this total box, and it won't let you move on until it adds up to that total. So for all of these data metrics, including race, ethnicity, and payer source, it's important that each patient is counted only once. This is the way that CCSP has always collected this data, even before my time. So we're making sure there's continuity between the years and how this data is collected and reported. So for example, if a patient had both Medicare and Medicaid, you would report them as having Medicare because that's that primary payer. And Medicaid is always considered the payer of last resort. So if they have both Medicare and Medicaid, Medicare would be that primary. So making sure each patient is just counted once to the best of your knowledge of their primary. Next page, please. All right, so moving into the fun stuff. This is endoscopy and pathology reports, which are really important, being able to interpret these both for supporting the data reporting, but also more importantly, understanding the results for your patients so that you can provide them the best navigation and making sure they're linked to the appropriate client care. So making sure, even though the provider has to be the one who delivers the results of the screening exam, if there is going to be additional touch points with the patients, it's really helpful to make sure they understood those results, did receive them, and understand the follow-up recommendations after they've been provided by their provider. And also making sure if you do see that a patient did have, for example, an advanced adenoma or a cancer, that they are linked to appropriate services for what will be the next steps for follow-up care. So if they're going to need another colonoscopy more frequently, or if they did get a cancer diagnosis, making sure they have been linked and contacted from providers. Okay, so endoscopy reports really focused on, has the information about why the colonoscopy is needed, the prep quality, what the exam result was, if it was complete to the cecum, and if there was a need for any pathology to be ordered. While the pathology report is after there was anything removed from the colon, it looks at what that ultimate diagnosis and result was, what type of polyp, or if it was a cancer. Next slide, please. All right, so we are going to look at a real example endoscopy report, and I'm going to have you all follow along and help pull out some of the elements that are part of the CCSP monthly report. So seeing where these come out of the endoscopy report. So I'm just going to go one by one and kind of go over some of the sections that are important within this report, and then have people put their responses in the chat for this mock patient. So this is not any real patient information. This was all made up, but it's a really good example of what's on an endoscopy report. So in this upper introduction section, it usually has the characteristics about the patient. So this is a 60-year-old male patient needing a colonoscopy. Elective means that it was planned ahead of time. And then any other information about the patient will be near this top part. So name, exam date, usually date of birth is also included, physician. And then the next section, indications, is why the colonoscopy is being completed. So for this patient, there was recent bleeding and pain centered in the left lower quadrant of the abdomen. So we're going to stop here, and I'm going to have you all put, for number one in the chat, what was the patient age, and then also why are they getting a colonoscopy? Are they getting a screening colonoscopy, a diagnostic colonoscopy, or a surveillance colonoscopy? So if you want to go ahead and put your answers in the chat for 1 and 2. Give it another 15 seconds or so for more people to put in response. Okay, so yes, This is a 60-year-old patient, and they need a diagnostic colonoscopy due to symptoms of colorectal cancer. All right, so, and thanks everyone for answering. Looks like everyone who responded got it correct. So great job, everyone. Okay, next, it will tell you about what happened with preparing the person for the procedure. So making sure the patient received all of the information about the benefits and risks, and then making sure medically that they were prepared and it's safe to go forward with the procedure, and that they were monitoring many of their vitals. What the medications is really showing what was ordered as that sedation medication during the procedure. And then in this case, they did a rectal exam before the colonoscopy. So next with the procedure, they're describing what occurred during the procedure. So it says the colonoscope was passed through the anus under direct visualization and was advanced with ease to the ileocecal valve. The scope was withdrawn and the mucosa was carefully examined. And then findings, they did find a polyp in the ileocecal valve and they describe it. So, and then also for, I'll just point out for this particular endoscopy report, there, it does not say whether the prep was good or bad, which it should have on them. Most do have on them. However, they also take pictures throughout the whole exam and have pictures of that colon. So you can see that this person's colon is really clear, has direct visualization. You can't see any bits of excrement. And so that would tell you that the prep was definitely adequate. So number 3, was the cecum reached in this colonoscopy? And then part A, will there be a pathology report? So cecum first, getting a lot of yeses. So yes, 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 yes. How they're describing the cecum reached in this particular report is that the colonoscope was advanced to the ileocecal valve. So in a moment, we'll go over a couple other names for how you can tell that the exam was complete to the cecum. So the cecum is number 6 on that picture of the full colon. So at the very end of it, that is considered the beginning of the colon and also is known as the ileocecal valve, cecum. And there's a couple other ways you can tell as well for different pieces that are all in this area that indicate that it was complete to a cecum. And so Marilyn, I saw your question in the chat about that. In just a few minutes, I'll go through a couple other ways that you can tell if it was reached to that full cecum. And then yes, there also will be a pathology report because they did remove tissue. So it's saying that they found a polyp, they described what the polyp looked like, and that it was removed. So that means that there will need to be a pathology report. And then this one is already telling you that they think it's a large sessile polyp, but the pathology report will have the final diagnosis of what type of polyp it was, and information about size, and if it has any dysplasia that would help make it advanced. And then it also does have these recommendations for the patient, including what they need to do directly after the colonoscopy for their medical care, the diet, And then here we can see when their next colonoscopy is recommended. So in how many years, based on the polyp found in the colonoscopy, is this patient recommended to have their next colonoscopy? And is it going to be a screening colonoscopy next, a surveillance colonoscopy, or another diagnostic colonoscopy? So when will be the next colonoscopy, and will it be screening, surveillance, or diagnostic based on a polyp being found? Give it another minute for a couple people to answer. All right, so it says colonoscopy recommended in 1 year. Patient should schedule a future appointment today. And then they'll receive the follow-up from their pathology, the biopsy and pathology report within 1 week. So the next one will be in 1 year. And because there was a polyp found, and they want to monitor that, it will be a surveillance colonoscopy. And often surveillance colonoscopies are recommended within 1 to 5 years, but it's based on the type of polyp or number of polyps that were found, as well as the patient's risk level when they would need a surveillance colonoscopy. But screening colonoscopy, if it was more on that 5 to 10 year period, and it would probably just say resume normal screening if it was just going to be a screening colonoscopy. For this one, because they want to look in 1 year based on a large polyp found, it's a surveillance colonoscopy. All right, good job, everyone. There's a lot of information, as you can see, in these endoscopy reports. But these are the pieces that are important for CCSP navigation reporting, as well as the monthly evaluation reports. So some of these other pieces could definitely be interesting if you're interested in more of the medical side, but these are the areas where you can find the answers to what we need. And it's really to help both with that navigation into colonoscopy as well, or navigation for next steps and making sure the patient understands their results, as well as for seeing results of navigation. Was the prep good where they could visualize the colon well? And if the prep was good, as long as the patient didn't have any adverse medical events, they should be able to advance the scope all the way to the end of the cecum, and seeing if their colonoscopy schedule going forward is going to change, and what type of colonoscopy they might need in the future. Next slide, please. So, as I hinted before, the cecum, as you can see, is considered the start of the colon, but it's as far through the colon because the scope will start down at the rectum, which is technically the end of the colon, and it needs to be able to advance all the way through to the cecum. And so they advance it through the cecum to the cecum, just basically checking to make sure the prep is good at first. And then once they reach the cecum, then the GI provider, the gastroenterologist, will then start to slowly reverse back through the colon and look for polyps, taking many, many, many pictures as they advance through. But it's really important that they're able to get all the way to the cecum to look at the full colon for polyps. So the cecum can also be known as the ileocecal valve. And that's because ileo or ileum means small intestine, and cecal is for the cecum. So it's where the cecum meets the small intestine with that little dangly piece right there. Or it can be known as the appendiceal orifice, because it's also in the area of the appendix. So if you see any of these names, ileocecal valve, appendix, or appendiceal orifice, or terminal ileum, because it's the end of the small intestine as well, then the cecum was reached. So definitely important to review how the providers you all work with designate this on their endoscopy reports, but know that any of these terms can be used to determine if the exam was complete to the cecum. And if you're having trouble finding this on the endoscopy report, feel free to send us an example with any patient identifying information blocked out, or of course, ask your gastroenterologist office about how their providers are indicating this. All right, next slide, please. And then just as an example, again, we're going to be asking on that actual CCSP monthly report whether the screen was really screening for a patient who might be either an average risk or high risk, but they have no signs or symptoms of CRC, or personal history of colorectal cancer, polyps, or gastrointestinal disease. So they do really need a true screening exam, and they might have been screened previously. Signs are for diagnostic, that's signs or symptoms of colorectal cancer, which we've reviewed before. And then up until this point, it's been considered a diagnostic exam if someone has a positive fit in FOBT. However, the medical community and the screening community is now moving towards having this covered as a screening exam, not diagnostic, so there's not out-of-pocket cost to the patient. However, since we're midway through our grant period, we don't want to change the definition midway through, and this is still in the transition point of not being considered a diagnostic. So right now, diagnostic for us is considered symptomatic or a follow-up to a positive fit or FOBT. In the next grant cycle, we'll be moving away from the positive stool tests or other exams being considered diagnostic. It's part of the screening process. And then surveillance is for people who have a previous history of colorectal cancer, polyps, or gastrointestinal disease, or a previous abnormal screening colonoscopy. So that's why that patient, their next one will be considered surveillance, while the current one was considered diagnostic. And then that prep quality can be indicated as adequate or not adequate, or by the pictures. And then we just went over all of the ways you can tell if the cecum was reached. Next slide. And then pathology report will come usually within 2 weeks of the colonoscopy. They'll receive the endoscopy report directly following the colonoscopy, but the pathology takes a little bit of time to examine any tissue that was removed during the colonoscopy and what type it was. So for this one, we can see that it was found in the cecum. It was a hyperplastic polyp and no dysplasia. They'll also describe the size of the polyp, and that might come under gross description, but they should likely include whether or not it has dysplasia, what the size is, and then what type it's considered. Next slide. So for CCSP, we have the polyp categories broken into whether they're considered benign, just based on risk level. So how likely the cancer or the polyp is to develop into cancer. That's how the categories are designed for whether it's considered benign, precancerous, high risk or advanced, and then is it cancer or adenocarcinoma. So all polyps are benign because they are not cancer. However, they, as we went over with the sequence, they have different risk levels for turning into cancer at this point. And the ones we're most concerned about are high risk. However, precancerous are the ones that are most frequently identified from our large CCSP clinics that are having hundreds of patients go through colonoscopy. So as you can see on here, it's some of them, it's really important what the size is. So if it's less than 1 centimeter or larger than 1 centimeter, does it have dysplasia? Does it not have dysplasia? That can change what category it's in. So any that are considered more than 1 centimeter in size or 10 millimeters is considered a high risk or advanced one. And then there's certain subtypes that are also considered high risk and advanced, but those that are less than 1 centimeter generally considered not as high risk. And then hyperplastic is just one example where if it's less than 1 centimeter, it's considered benign, but if it's larger than 1 centimeter, it's considered high risk. Tubular, also whether or not it has dysplasia is really important. So we really recommend that all patient navigators download and print a copy of this guide to reference for your monthly evaluation report. And I'm happy to spend any additional time with people helping you review this if you're newer to this. And let us know if you have a polyp you can't find and need help categorizing. All right, next slide. We're almost done.
And then Elsa, did you see the question on the chat? Did you address that?
Oh, thank you for reminding me. Okay, so the question was if a patient had a positive FOBT or other testing, it would still be considered screening. So this is where it gets a little bit tricky just in terms of how the landscape is changing for colorectal cancer screening right now. So up until 2021, it's always been considered that those positives are considered diagnostic rather than screening. So that's how CCSP has been tracking it. However, being a diagnostic colonoscopy means that a patient might incur out-of-pocket costs. So the policy community has been fighting really, really hard to make sure that it's no longer considered a diagnostic where a patient might incur out-of-pocket costs. So going forward within 2023, patients should no longer receive out-of-pocket costs for those follow-up colonoscopies. However, for CCSP data reporting purposes, we've always been tracking it as diagnostic. So for the remainder of this grant cycle, just this fiscal year, we're still tracking that as diagnostic so that we're not changing the definition midway through. But going forward in terms of implications for your patients, it's all part of the screening process, and they should stop getting those out-of-pocket costs for that follow-up colonoscopy. So it is moving towards being considered just screening, but for CCSP reporting, we're still going to continue to track it as diagnostic, and it says positive stool tests in the definition. Yes. Okay. So we're about out of time, so I'm not going to go through and have you right now identify the polyp categories in this pathology report. But next slide, Wesley, and I think it should tell you the answer. Oh, go back. If you can go back. Yeah, there we go, right there. So for this one, because it was a tubular adenoma, it didn't have high-grade dysplasia, it would be considered a precancerous polyp. And then the second part, fragments of colonic mucosa, is not actually a polyp. It's just mucus in the colon. Part B fragment of colonic mucosa with no specific pathologic abnormalities, same as that second part of A. It is actually not a polyp. So they're not saying it has any abnormalities. It's just colonic mucosa. So not actually considered a polyp for our purposes. Next slide. So these are the categories. Again, there will definitely be a pathology report if any tissue is removed, but not all tissue is considered polyps. And patients might have multiple polyps removed on during their colonoscopy. So just as the other categories in our monthly report, you only need to report for the most serious, most advanced polyp type that was found for that patient. So if they had a high risk and a benign polyp, you would just report that patient as having high risk polyps, because that's really going to inform their surveillance recommendations going forward. Next slide, please. And then just the last things the report asks for are you navigating patients also into other screening programs like WWC? And then what types of barriers did you assist patients with? What types of barriers did they experience? What barrier reduction activities did you help them with? Again, this helps us answer our evaluation questions and also see what types of resources would be helpful for clinics to help address these barriers. Next slide. So just to wrap it all up, we really recommend, we have some tips to really help you have accurate reporting, using those data collection templates, making sure you're familiar with the eligibility criteria, having processes in place to track those no-show rates, cancellations, whether patients are getting services from other screening programs. Use that polyp categorization guide, have it ready to refer to. And then if you already submit your report for the month and you have additional data to report, submit that data in a second report. Let me know if there's additional data and I'll make sure that I understand it's not a duplicate. So happy to help any of you at any time. Feel free to reach me by email or phone, and I'm happy to provide one-on-one support, especially if you're new to this process. It does take a little bit of getting used to and really getting familiar with the endoscopy and pathology reports. So I think that's everything we had for today. I'm not going to spend too much time. I'm not really going to go into billing since we already touched on that before, but there is information on the slides in here, what's eligible for barrier reduction funds. Again, it's not for anything that's a direct medical service, so not for those actual colonoscopies, not for the stool-based tests, but we do have some limited funds for this. So we have a specific barrier reduction invoice, and we have our specific colonoscopy navigation invoice. Your clinic should all have copies of these, but if you need any assistance with it, please let us know. And examples of costs that are eligible for barrier reduction are on that right side. It's use it or lose it. We have one budget for the whole program for each fiscal year. So definitely let us know if you're planning on using those funds. All right, thank you so much everyone for sitting with us for the whole afternoon. If you want to further test your knowledge, we have some true false questions and links to all of our resources. And please feel free to reach out with us at any time. And I hope you have a great rest of your evening. We'll be sending out all these materials, and we do have a brief evaluation to let us know what you thought. All right, we're only about 4 minutes over, but feel free to let me know if any questions came up. Take care, everyone. Bye-bye.
Bye, thank you all. Be sure to fill out the survey when you leave the meeting. It helps provide feedback. And yeah, we'll see some of you tomorrow.